Welcome back. We are now on part 3 of the training. We will be addressing how to respond to patients with support, risk reduction, responsive healthcare, and resources.
But first, Dr. Linda Chamberlain will explain why we're teaching this particular approach.
So the U.S. Preventative Services Task Force now recommends screening women of reproductive age for domestic violence. And an important part of that evidence to support their recommendation is what we have learned in randomized controlled trials with the safety card. The first safety card trial that was done was very, very interesting because it had to be stopped midway, and the reason for that is women were asking for more than one card. They wanted a second card to give to a family member or a friend. This is an extraordinary opportunity for when we can see peer education, when we have patients who want information that we have so that they can share it with their family and others. We know we're on the right track. And so that changed the protocol in this randomized controlled trial that each woman got 3 cards, safety cards, to share with others. What we saw in this evaluation of the safety card approach was something that we have never seen with other evaluations of domestic violence screening. It actually reduced the risk or experiences among women who had experienced domestic violence in the past few months of pregnancy coercion, being coerced by a partner to be pregnant when they didn't want to. And then among women, regardless of whether they had experienced domestic violence in their relationship or not, they were more, in the past, they were more likely now to choose to leave a relationship that they thought was unhealthy or unsafe. That's the kind of data where we realize that using this approach is making a difference in the lives of women and their children.
You may be thinking, okay, so it worked well in a supported study in the lower 48, but how can I make this work in my patient population and setting? That's what the Alaska specific cards we introduced in Training 2 and the skills that we're teaching in Training 2 and Training 3 address, how you can make this work and make a difference in the lives of your patients in your settings in Alaska.
Sometimes how to respond is one of the biggest barriers that providers face. They don't know that they have the words, they're not sure what to do, they feel like they're opening up Pandora's box, and they won't have time or the resources to respond. The good news is that just providing validation and support can be really healing to people. Caring is curative, and it doesn't necessarily take a long time to provide validation and support to someone. What we know from research is that women who talked with their healthcare provider about abuse were about 4 times more likely to use an intervention and 2.6 times more likely to exit an abusive relationship. You as a healthcare provider really can make a difference in someone's life. So we're moving on to panel 5 of the comic, which is how to respond. So if the patient says no when you ask them, are any of these things in the card an issue in your life? Or if you ask a direct question and they say no, you still have an opportunity to keep the door open, to respond in a way that lets them know that you're there for them, that they can come back if anything changes, and you can still give them a card. One thing that's important is that you want to make sure it's safe for the patient to take them. So you can say something like, if it's safe for you to take these cards, you can have as many as you like to share with friends and family. The reason is that if somebody is in an abusive relationship, they know best what's safe and if their partner might find them and be angry if they found that card.
So it's really important when a survivor of any age comes forward and talks about having been abused or assaulted, for anyone to believe the victim and to validate and say things like, I'm really sorry that happened to you. And the reason it's important is because it takes a lot of courage, and it may be the first time that a survivor had enough courage to say something. And for children, it may come out not necessarily as a direct statement, but as a situation where they did not intend to say they were victimized. And so it's really important not to put any kind of shaming words or blaming words or any kind of sense in that direction for the survivor. The survivor needs to feel believed and supported and validated, and to come to that place where they know it's not their fault. They did nothing wrong. And to be thanked for coming forward, having had the courage to say and speak their truth.
Thank you for telling me that. That was really brave of you.
Thank you for sharing this with me. That took a lot of strength.
So I'm really, really sorry this happened to you. And I appreciate you having the courage to share that with me. I know it takes a lot.
Opening up to anyone, including a healthcare provider, is a really scary thing. It's a risk someone's taking, and it is brave of them to do. So we do want to validate that.
That sounds so hard. I can't imagine what these last few months have been like for you.
That sounds really stressful.
Some people might say, why do you have to say that sounds really stressful? Like, of course it's stressful. Why would you state the obvious? But it actually is really helpful and healing to hear your own experience validated. So for someone who has been abused, they have often been told by their abuser that they are exaggerating things, that they're too sensitive, that they're crazy, that they're making things up. And so for you to hear about the stress in their life and validate that that is indeed stressful, or that sounds really scary, or that sounds really hard, that lets them know that their experience is real. That validates their lived experience and their trust of themselves.
You don't deserve this. It's not your fault. Thank you for telling me that.
It's not your fault.
So please know that none of this is your fault. You did nothing wrong. And we're going to do whatever we can to make sure that you get the help that you need. But you're on the right journey. You know, talking about what happened to you is the first step. So thank you.
It can be so powerful to tell someone that it's not their fault or they don't deserve this, because they've often been told by their abuser or their abusers over time that it is their fault, that there's something wrong with them that's causing the abuse. We also hear a lot of these victim blaming messages in society, sometimes in our families, and so you have the opportunity to offer a different narrative that might help reshape how they think about themselves.
They have believed and operated for many years, oftentimes believing that it was not okay to talk about their truth. And so believing and living their life in shame is crippling. And what it does is really, it's that idea that there's something wrong with me. That's why it's really, really important when people do come forward and say, something happened to me. To believe them and to validate that they did nothing wrong, and to congratulate them really for having the courage to come forward.
Thank you for sharing some of your experience. It sounds like that was really difficult, and it's been difficult for a while. But it also sounds like you're taking some really good steps for your safety and the safety of your children. So I want to see if there's anything I can do to help you. It's totally up to you what we talk about or don't talk about, but I want you to know that I'm here to listen and support you in whatever ways I can.
I'll show a brief segment of a video by Futures Without Violence about how a healthcare provider responds with validation and support and empathy to a young woman who has experienced reproductive coercion and is now pregnant.
I don't know, I guess I just missed a couple.
I'm really sorry you have to go through all this, Alicia. Is this something that you can share with friends and family?
No, I'm too embarrassed. I mean, I know better. I'm not supposed to be in this kind of relationship.
Alicia, all kinds of women at different points in their lives find themselves in this situation. I'm not an expert in controlling or abusive relationships, but I know someone who is. Would it be okay if I called my colleague Debbie? She can help you develop a safety plan, think about next steps. She's helped a lot of women in your situation. She can come here to the clinic if that's what you want to do, or you can even talk to her on the phone.
Okay. Yeah, I'd like to talk to her.
Thank you for trusting me with your story. For now, I want you to get support and be safe so that you can make the choice that's right for you, not out of fear of what your partner will do. Hi, Debbie. It's Lisa from the clinic. I have a client here, Alicia, who has some things she wants to go over with you. You have time now? Great. Hold on one sec.
Hi, Debbie?
So what did the provider do well in that video? Yeah, so some of the things I noticed are that she obviously showed with her tone of voice and her body language and her words that she cared. She also let Alicia know that she wasn't alone in experiencing this. And she offered resources and support and help to make her own decision. So we're at panel 6 in the comic, which is about following up or helping with safety and health needs. As we talked about in the first training, domestic violence affects many health conditions. And so you have an opportunity as a provider to help make the connection for the patient between their health conditions or health behaviors and the stress that they're experiencing. And that can feel really eye-opening as well as validating for them. Now, this picture is a little funny because it has a gastrointestinal tract and an IUD, and obviously they have nothing to do with each other. But in this case, the example is that the patient may be having GI problems and also need a safer form of contraception. And this is where you can talk about both of those kind of options. It's very important not to should people, not to kind of tell them what to do, because that can feel very shaming and disempowering. So what we can do is offer concern and offer information. For example,
Thank you for sharing that with me. That was really brave of you. I actually have some resources here on this card. It talks about some of the relationship issues you shared with me, similar to that. It also talks about some of the health issues that may be affected from that stress that you're dealing with right now.
So what you've told me seems really stressful and very, very, very hard. And for many people, we actually help our stress a lot by eating and stress eating. Do you think that's happening for you?
So we know that kids and teenagers especially have a really strong connection between their mind and their body. And when they're feeling a lot of stress, oftentimes that can come out as symptoms in their body like bad stomach pain, bad pain in their arms and legs, headaches, vision changes. And this is not saying that they're making it up in their head at all. This is their nerves playing tricks on them. And we need to retrain their body to take back control over those nerves.
I want you to know you have the right to decide if you want more children or not.
And so if you are drinking, I want to help encourage that you can tell us, and we'll also just focus on how we can best work with you in figuring out, what's driving you to drink, how we can work on a safe way of minimizing the alcohol possibly, or creating a safer living environment that allow your baby to grow healthy. Because we have studies that show that these alcohol, tobacco, and drugs do affect the baby and can cause long-term damage.
Thank you so much for coming in and telling me about that, about the effects of domestic violence that you're seeing on your kids. It's really brave of you to come in, and that's a really important first step in finding safety for yourself and your kids. A lot of people think about the way that domestic violence or violence in the home can affect kids, and many people think that their kids are sleeping during it and so that it's not affecting them. But we've actually learned some research about effects of violence on kids in the home, and they found that most of the time kids actually aren't sleeping, that they are aware of what's going on, and the kids that it can actually affect the most are babies, because the way their brain is developing can really pick up on how safe or unsafe their environment is, and so we're seeing that it affects babies a lot, just as it affects other kids as well.
So I have worked with so many families, and oftentimes what I'll hear when I'm working with parents is that when I'm working with the non-offending parent is that this happened to me too. And so a lot of times what may be happening when you're working with your child, and you know that your child has said these things, that many times what's happening is that your stuff is being triggered. Okay, and so just being aware of that, I know this is really, really hard, You did the right thing by believing your child, and it's really, really important what we know in working with children, that if they have a parent that believes them and is supportive, that's like 80% of their healing. And it goes so far. And I mean, it takes courage knowing, just knowing to be able to face this. So, and just with that, it's important to take care of yourself as well, and to know your triggers, get help, talk to people. And I'm sorry this is happening to your family.
And I want to show you a video of how a provider is explaining reproductive coercion to someone who doesn't realize that this is happening in their life. Because you might be in a position to help someone understand that what they're experiencing is abusive or is coercive. And how to do that in a non-judgmental way.
Hi Maya, how are you today?
Good, thanks.
Okay, can you just tell me what you're here for again? I'm sorry, my computer's being slow.
For a repeat PAP. Also, I had a condom accident yesterday. So since I'm here, I need...
You need a repeat PAP and emergency contraception?
Exactly.
Okay.
And I know I can get it at the pharmacy, but it's crazy expensive, and it's free here.
Yeah. Same partner?
Yeah.
Okay. It looks like we've given this to you several times in the past few months. I'm sorry, my computer's being slow. Can you remind me what methods you use again?
Just condoms.
Okay. Would you be interested in using something else in addition to the condoms?
No, the hormones make me crazy, and I gain weight. I don't want to gain weight. I'm just going to stick to condoms.
Okay. Well, ultimately it is your choice, but there's some great effective methods with no hormones in them.
I don't know. My boyfriend doesn't like anything that isn't natural. He thinks it's unhealthy and could have side effects. And those side effects can contribute to women not being able to get pregnant when they're older.
Okay. Well, we have a lot of data that shows women have no problems getting pregnant when they've used birth control. And one of the things that worries me when I hear combinations of things like this, the condom breaking so much and your boyfriend not being supportive of you using an effective birth control method, is that he may be trying to get you pregnant. Do you think he could be breaking the condoms?
Well, he has been talking about wanting to have a baby with me, but I've been clear that I don't want one. Well, at least until I finish college and figure out my life, career kind of stuff.
Mm-hmm. Well, this may or may not be the case for you, but sometimes men will use pregnancy as a way to keep you in their life forever.
Really?
It can really be a form of control. Hearing what you've told me makes me wonder if there's been other situations where he's tried to be in control. Has he tried to hurt you in any way?
No, nothing like that. He's never hurt me. But he's definitely upset about what's in the cards for me after graduation. It's weird. I never really thought about putting these pieces together before.
Well, if you really want to avoid getting pregnant, there are methods of birth control that are totally safe and effective without hormones. This is the IUC. It's inserted into the uterus. It lasts up to 12 years, and you could remove it anytime you want to plan a pregnancy.
Do those strings stick out? Would you feel it?
Potentially, he could feel it, but we cut the strings short and they curl around the cervix. But we usually leave a small bit of string so that you could feel that the device is still in place. We could cut the strings off completely because there are some women who don't want their partners necessarily knowing about the device, and we'd have to use an ultrasound to remove it. Does the IUC sound like something that could work for you?
It would definitely be a lot less stressful, especially if the condom breaks again.
So what did you notice that the provider did well? Yeah, without lecturing or anything like that, she helped Maya to see the pattern of broken condoms and the partner not wanting her to be on birth control could be about reproductive coercion. So she didn't tell her this is happening, but she did give her information and suggest and say that she worried about that happening. That's a way of giving information and expressing concern rather than telling her what to do.
In working with women to help figure out what birth control they want, if they're wanting birth control, I often recommend a LARC first, which is long-acting reversible contraception. The reason why I recommend these is because they're the most effective and the easiest to maintain. You basically don't have to remember them. Those include the Nexplanon, which was formerly called Implanon, and also the IUDs, Paragard, Mirena, and Skyla. If a woman is wanting to get more information with those and she's in a domestic violence relationship, I often ask her if her partner were to find out about this method, would she be safe, or what does he do in controlling her reproductive care, and is that method going to work for her to help protect her safety? So in counseling, if we identify that a partner is being controlling with reproductive methods and happens to be controlling in a method where he is monitoring when she menstruates, then picking a birth control method that keeps a regular menstrual pattern is important so that she could keep that birth control secret, if that's what she's needing, is to keep it more secret from him. So birth control that does not change when you menstruate is the Paragard IUD. She would continue to have monthly menses as long as she's ovulating regularly. And that's an important discussion to ask her is with menstruation, would he identify whether or not she had a birth control method just by her menstrual pattern? With the Nexplanon, you could have no menses, you could have irregular menses, or you could have heavy vaginal bleeding. And would that change the impact? Or would he pick up on it? If she is a woman who has heavy menses and cramping and would prefer to have lighter periods, it's also important to counsel her with the Mirena. If she's wanting the Mirena or the Skyla, is that they will reduce her menstrual flow and cramping. But some women, especially on the Mirena, 8 out of 10 women don't have a period on it. So if she started not having a period without birth control, would that put her at risk? If she were to have an IUD, for example, one of the potentials is that the partner, through intercourse, might feel those strings of the IUD. If he did, would he be knowledgeable of that birth control method, and would that matter to him? Like, would he want her to pull it out? Would he pull it out himself? It is possible that we could cut the strings shorter so that they are not within the vagina, so we wouldn't feel them. But counseling as far as how the birth control changes your body and how it can be perceived, as far as like the strings can be felt. If it's a Nexplanon, it can be palpated under the skin. If he found it, or if he was knowledgeable of that, how would that be in that relationship, and how would that affect her safety? So in working with an adolescent female, it's really important to keep LARCs within your options of birth control methods, because not only are they the most effective, she also doesn't have to maintain them. It's a misnomer to say that teenagers or women who haven't had a baby before aren't eligible for a LARC, particularly an IUD. Even the American Academy of Pediatrics recommends LARCs or IUDs even for teenagers. So if that is something that you feel, working with her in that counseling, that might be the best coverage for her, she is eligible. And it's really important to get that to her in a timely manner and not delay starting a birth control method, particularly a LARC. You also don't have to be on your period in order to get an IUD.
Another safety consideration is that if the patient wants depot shots, you might want to ask, can you return to the clinic for your shots, or is that partner going to interfere with getting that regular care? If you are giving a form of oral emergency contraception that requires the patient taking pills home, then one option you can give is to offer it in a plain envelope or an otherwise identified envelope or bottle so that the partner can't identify it as emergency contraception. There are a number of safety issues to consider around STI treatment and partner notification. Notifying a partner can be a time when abuse escalates, where a victim is more vulnerable to abuse. Sometimes the partner will have had other sexual partners and brought that STD home, but might still accuse the victim of having contracted it with another partner. It can just be a dangerous time, and so rather than simply asking the patient to go home and notify the partner or to bring expedited partner therapy home, you want to assess for whether that's safe or not. Asking something like, is it safe for you to tell your partner? How do you think your partner will react? Will it be safe for you to bring the expedited partner therapy home?
Because conversations about STIs, partner notification, and safety can be tricky, I'll show you a little bit more from the Futures Without Violence video about Jocelyn. You were introduced to her and to her controlling husband in the second training, and now you'll see her partway through her visit with the provider.
To get a sense of your sexual history, so I can make sure you don't get this again, have you had other partners since you've been married?
No. Of course not.
Okay. How about your husband? Is it possible he has other partners?
I guess it's possible.
So, have you spoken to your husband about PID and chlamydia?
No. I was hoping they screwed up the test results. I mean, that happens, right? Sometimes?
That's not what happened this time. And we did test you for gonorrhea, and that was negative. But we should also test you for both syphilis and HIV today.
You're kidding.
No, I'm not. Anytime you have a sexually transmitted infection, it puts you at greater risk for the others.
Of course.
Jocelyn, what would happen if you told your husband about the infection? If it would help, we could explain all about it here in the clinic. I understand he came into the clinic with you today. Would it help if I talked to him and explained?
I don't think so. I don't know.
Another idea is to have the health department call him. They do this kind of thing all the time. They would call him and tell him he's been exposed to chlamydia, but they can't tell him where they got the information from.
I don't think that's gonna help.
Jocelyn, are you afraid when he finds out he's gonna hurt you?
He's gonna be really, really mad. He's not gonna believe I didn't do something.
Okay, this seems really hard. And I hear this from a lot of patients. I'm not an expert in how to help with the situation with your husband, but I know someone, a colleague, Jackie. She really understands, and she can help you with a plan to be safer. Are you afraid to go out in the waiting room right now?
I just can't. Okay, it comes in waves with him. I can't tell him right now. He'll blame me. I can't.
Do you think he could become violent with you or someone else in the clinic?
I mean, he's not gonna act up in public.
Okay. Because this is so common, I'm giving these to my patients. It's all about relationships and what women deserve in relationships. Being hurt and being afraid shouldn't have to be a part of that. There are hotline numbers on the back. I called them myself. They're really good. And they're there 24/7 just to listen, or they can help you with a safety plan if you need that. So let's finish with your other tests and take care of the rest of the visit. And then if you want, you can borrow my phone or have me call Jackie or the hotline. Okay?
Okay.
Another thing is that in considering treatment options, especially if someone needs ongoing treatment, such as for HIV, you'd want to assess with the patient whether they will be able to return to the clinic regularly or whether abuse might be a barrier to regular care, and figure out the safest treatment option based on their experience. Lastly, some other safety issues to consider is whether the abuse is exacerbating chronic conditions, whether the abusive partner is denying medications or treatment, and that may be contributing to their chronic condition. For example, an abusive partner might hide the victim's asthma inhaler, even smoke around the victim, triggering their asthma. And what I've heard from people who work in diabetes management is that some of their patients have a harder time following the diet and exercise plans that they're given because of a lack of a supportive partner and because even an abusive partner who interferes with or controls what they can and can't eat or can and can't do. And so we do want to consider safety in the context of their health condition. So, of course, in the context of a healthcare visit, you can't provide every service that the patient needs, and you're not expected to. That's why we give referrals, and that's why we have other resources. But how we give referrals matters. Rather than simply giving someone the phone number or telling someone about a service, or even kind of sending them to another department to make that referral, the more that we can have a warm handoff, a supported handoff, the more effective that referral can be. And what we mean by warm is that if you know the service and you can describe it well, the patient is more likely to have an understanding of what that means and be open to the idea. For example,
thank you so much for sharing all this stuff with me. I know that was really hard to do. This is something that I'm not an expert at in talking with folks about relationships and safety, but one of my colleagues is. She's a social worker here at the hospital. Is it okay with you if I go and get her so that I can introduce her to you and you guys can talk more?
I'm not an expert on difficult relationships or the kinds of problems you've been telling me about, but I know some people who are. The ladies over at Tundra Women's Coalition have helped so many people. If you'd like, we could use the clinic phone here, and you could talk with an advocate there. There are even advocates who speak Yupik if you'd be more comfortable speaking in Yupik. They can listen to you, provide information, or help think about ways to stay safe. Would you like me to make the phone call and you can talk to them in private?
Would you like to talk about some of the options that you have? It's totally okay if you'd rather not talk about things right now, but I'm happy to talk about them with you if you feel like this is a safe space to do so. One of the options that you have is to talk with an advocate at our local domestic violence sexual assault agency. An advocate is someone who can talk with you about your safety and any plans that you feel like you should make for your safety and the safety of your children. So that could even be staying in a shelter for a little while, or getting a protective order. These are things that an advocate can help you with. If you would like to talk to an advocate, we can call from my office if you feel like that's safe to do so. I can be in here with you, or I can leave you alone in here for a little bit to make that phone call, whatever you would prefer. I do have the number here if you would like. Advocates are available to talk with you 24/7, and so if you want to ever make that call from here, you're always welcome. Even if you don't have an appointment, you can come in and talk with our person at the front desk or meet with me, and we can make sure that there's a quiet place for you to make that call. You're always welcome to come back here.
This is a brief video from Futures Without Violence of one of these warm, supported referrals for a Spanish-speaking patient.
While we're waiting on this, Martha, I'm wondering if you'd like to talk with someone about when you're having a hard time in your relationship. I have a really kind colleague, Nina, who works for a local organization that helps women who are having trouble in their relationships. She works with a lot of women who come here to the clinic, and she could even speak with you in Spanish if you'd like. She runs a weekly group for women to talk about their concerns in their relationships, and she also has a safe shelter where you could go to if you ever need to leave your house in a hurry for safety. Would you like to talk with her?
Just talk.
Yes, and you can talk without giving your name if that would make you feel more comfortable. I can go ahead and make the call to get things started if you'd like.
Maybe. Yes.
Hello, Nina. Hi, it's Dr. Koppel. How are you? Well, I'm sitting here with a Spanish-speaking client. She has some questions for you. Here.
Hola. Sí. Me llamo Marta. Bien, gracias. Quería hacerle algunas preguntas.
Now, as providers, you may not always know what resources are available in your regions, which is why we created these user-friendly visual resource guides for all domestic and sexual violence services for every region of Alaska. They're available on the Epicenter's Healthy Families page. You can select and download any of the regions. I'll give you an example using the Anchorage region. So the beginning of each guide begins with emergency contacts and a full program directory, followed by a section on surviving abuse. And the first part of this is about reporting options for children and teens, describing what child advocacy center is available in the region, followed by reporting options for adults, and then information on shelter options. And this includes photographs of shelters to show that it's a warm, family-friendly kind of place. And you can use the photos to go over this with your patients and say, you know, this is a shelter, you don't have to go there, but this is an option, and show them what it looks like. And then it goes into advocacy. Who are the advocates? What do they do? What services are available if you are at the shelter or even if you're not at the shelter? Then the next section is about prevention. And so you may have patients interested in this, but one of the primary audiences of this guide is for you as providers, so that you know what's available in your region for survivors and then for prevention. It talks about youth education opportunities, ways youth can get involved in prevention and wellness activities, trainings that are available for your staff and for tribes and professional groups in your region, and support and education and empowerment groups in your region, as well as grassroots community efforts and ways that you can get involved. The last section in each guide is for those who are abusing others. And so this talks about better intervention programs in the region and whether or not there are those options. So again, this guide is mostly to get you as staff comfortable with understanding what services are available in your region so that you can talk about it with your patients. But it's also something that you can give with your patients if they want. We are discussing again policy and practice implications for your facility. One of them is to have someone in charge of regularly stalking and making sure that the teen card, that the girl and women card, that the resource guides are available, that the new posters are available, making sure that those are in each exam room and that providers know how to find them. Another implication is to have an in-house social worker or behavioral health professional or a victim advocate or another staff who can support patients with referrals, so that if you as a provider don't have time to do that really supported referral, that you have someone who can do it. You may be able to house a victim advocate in your hospital, or you might be able to have an MOU with your local domestic violence organization so that advocates are able to respond to meet with patients at the hospital, and so that you are used to making those phone calls to them. The domestic violence organizations are only available in the hub communities in rural Alaska, and so if you're in a village clinic, you can still have that relationship with the advocate over the phone.
There are some exceptions, though. A few villages have developed victim advocacy services and either have a shelter or a safe house or provide quick transportation to one. A few examples are St. Paul Island, King Salmon, Craig, and Emonic. Many other villages are involved in prevention and crisis response programs, though, and they work in coordination with the shelters and the hub communities.
We talked in the second training about how to let people know about the limits of confidentiality and when you would have to make a mandated report. If you do end up having to make a mandated report, you want to do that in a way that minimizes the trauma of that experience. It can be a really upsetting experience for patients. And so some basic principles are to acknowledge the patient's feeling about the report, to inform them about the process of reporting and what to expect, and to involve them. You can make the report with them, or you can ask them to tell you their safety concerns, and you can include those in the report. So acknowledging them, right, keeping them informed and keeping them involved as much as possible. For example,
I know this is something you may not want to hear, but like I said at the beginning of our meeting, this is one of those things I do have to report, but we can do it together in a safe way.
And I'll show a brief example of that with a teenage victim.
Also, I want you to come back in 3 months to test for HIV, just to make sure, okay?
Thank you.
So, Olivia, what happened to you at that party, someone having sex with you without your consent, it's not your fault. And it's a crime. I'm not an expert on sexual assault, but I work with these counselors at the local program, especially this woman, Jessica. She gets it. And she can go with you to the ER, get a specially trained nurse to give you...
No, I don't want anything like that. I'm 15. I was just stupid at a party. And I don't want to talk about it.
Okay. Just so you know, you can talk to Jessica whether you decide to have the exam or not. Also, so this is the national hotline on the back of the card here, RAIN. They're open to talk to you 24/7. It's all confidential. And, you know, they're really supportive and nice. So, Olivia, do you remember when we talked earlier and I said that there were some things that I would need to report? This is one of those things.
What? No, you can't. I mean, I wasn't even supposed to be at this party. My parents don't know I was at this party. My boyfriend doesn't know I was at this party. You can't.
I know this isn't what you want, and I don't want to make this any harder or more stressful than it already is.
Don't.
Olivia, you do have some choices here. Okay, I have to make the report, but we can do it together. You know, you can sit in when I call it in, and I can put a note in the report about what you want to have happen, the safest way for your parents to be told, that kind of thing. But I do need to make the report whether you want me to or not, even whether I want to or not. So, what do you say?
You have to.
Yeah, I do.
Then I guess I want to hear the call.
So what did the provider do well with Olivia? Yeah, she was compassionate, she gave information. She also waited until the end of the visit to talk about mandated reporting because she wanted to have Olivia's kind of full attention while making sure that she gets the treatment that she needs and the resources that she needs. She, of course, had talked about the need to make a mandated report earlier in the visit. She was able to reference that, so Olivia didn't feel betrayed and blindsided by that report. Of course, Olivia was upset about it, but she acknowledged Olivia's feelings, empathized with her, and when Olivia kept pushing back and saying, no, don't do it, she didn't get in a power struggle with her. She let Olivia know that she had options, and she gave Olivia those options and involved her in the process. So the last step is documentation. We won't go into this in a lot of depth, and you can get more training on documentation, but some important things to note are to make detailed objective observations, including body maps, any evidence of injuries, quotes from the patient, and observations of their demeanor, affect, behavior, etc., observations of controlling partners, any legal recourse taken or referrals made. The most important thing is that you do not want to write no domestic violence, because even if the patient didn't disclose to you, saying that there's no domestic violence could be used against them in court. One of the values of having these detailed objective observations and documentation of injury is that if the patient does go to court, that's available to support the evidence that they were abused. With every patient that comes into your office, you have an opportunity to provide education about healthy and unhealthy relationships, their rights and their options, to provide resources for them to take home with to their family and friends, to potentially break the isolation that they've been experiencing in an abusive relationship, to offer options for safety, to help address health risks that have been exacerbated by abuse. We don't always know which patients have been abused and which haven't, so that's why we want to make this opportunity universally available. And also ask targeted questions for specific kinds of visits and injuries in a compassionate, non-judgmental, normalizing way, like creating safe environments and opportunities for patients to talk and get resources.
I want you to walk away from this training feeling like this is doable. immediately doable, even within the many demands of your busy settings. I want you to feel confident that with small changes in language, tone, and practice, and with these materials, you can help prevent abuse from ever happening when you're working with young people and teaching them, and that you can help victims and survivors of abuse and their children. I want you to feel effective. So here's the perspective of one very busy provider.
Knowing that I may not be able to help them all, but at least, and it does make a difference, it may make a difference to that one. If I just make a difference for that one, knowing that her birth, that might change, that might be the catalyst for her family and the rest of her life. And so knowing that if I've had a bad day and I feel like I haven't been effective, is knowing that I don't know all the ramifications of what I've done, and I will never know. But doing your best to go forth knowing that you probably made an impact in allowing that woman to change her life just by showing respect and letting her know too that she is also capable of these choices and change.
So I hope you will be able to use the resources that we shared, the safety cards, the resource guides, the posters, and the principles to create these safe environments for patients. Not only to help your patients, but help their children, their families, and children to come. We're addressing this because we want to stop abuse and violence now and reduce those risks, but also stop it intergenerationally and create a healthier future. So thank you for attending, and please do not hesitate to contact me with any questions or concerns you have. Thank you.